A patient has an acute hypersensitivity reaction. For a serious reaction, administration of both diphenhydramine and famotidine results in a synergistic, I didn't spell that right, sorry about that, in a synergistic histamine blockade that is better than diphenhydramine alone. True or false?
True.
That's right. Yeah, so I know this may seem basic, but it's still really, really important, right? The basics are very important. So diphenhydramine, what kind of drug is that?
Benadryl.
Well, it is Benadryl. That is correct.
Antihistamine.
Yep, it's an antihistamine. Is it a first or second generation?
It's a first gen.
Perfect. It's a first generation antihistamine. So it's an H1 blocker, right? What's famotidine, usually spelled correctly? What's the other name for famotidine?
Pepsid.
That's right. And what kind of a drug is it?
H2RA.
That's right. It's an H2RA. Sorry, I get excited when I talk about Pepsid. It's like my favorite drug. So when someone's having a really mild hypersensitivity reaction, sometimes we can get away with just giving them a little bit of Benadryl. When someone's having a more serious reaction, we want a full histamine blockade, right? Because histamine is a vasoactive amine, which means that when it kind of circulates throughout the body, it can do all kinds of things like suddenly drop blood pressure, which usually causes tachycardia and all manner of things. So this is one of the methods that we use to help deal immediately with a reaction. So if I gave somebody steroids, how quickly would that work to reverse an acute reaction?
Longer than the H2.
Yeah. How long about?
30 to 60 minutes.
30 to 60 minutes.
Exactly. So there's a lag time with corticosteroids. And one of the reasons I'm focusing on the hypersensitivity reactions is because in the ovarian cancer population, remember I talked about the fact that like you didn't see a whole lot of new drugs, right? I mean, you saw a few new drugs, but mostly we just talk about carboplatin, right? And cisplatin. Like we give platinums pretty much cyclically for patients unless they have resistant disease. So these patients end up getting exposed to tons of it, more than 6, 7, 8 doses. So their likelihood of having a reaction is much higher. And one of the things that you may end up responding to as a pharmacist in a hospital, even if you're, I'm an inpatient staff pharmacist, you may have to be involved in helping put medications on board or per protocol for a carboplatin desensitization. The reason we have these desensitization protocols is because, again, if I can't use a platinum, I might not be able to treat an ovarian cancer patient with the preferred chemotherapy, right? So there are other options, and I kind of talked about those, but none of them are really as good for somebody who has a responsive cancer to carboplatin. Does anybody have any questions about this? Okay, on to the next one. Please choose the correct statement regarding ovarian cancer. So most patients present in early stage of disease. Is that true or false?
False.
False. That's one of the reasons that makes ovarian cancer so crappy, honestly, because with breast cancer we have methods of screening, right? So, and we can tell women, do a self breast exam, things like that. There's really no good way of being able to detect ovarian cancer early. So 5-year survival rate is 32%. Is that true or false?
False.
False. It's a little bit better than that, right? I mean, we're still only about 46.5%, but it's better than 32%. So CA-125 is a reliable marker for screening and diagnosis.
False.
Yep, exactly. I wish it were. That would be great. And when it first was discovered, people thought, oh, this is going to be the new PSA, which has its own problems that we'll talk about next week. But what we found was that there's all kinds of issues with CA-125, and we'll kind of talk about that, I think, in one of the next questions. Epithelial histology represents 90% of cases. True or false? It is true. Yeah, I talked about a whole bunch of basically different cancers that arise from the different structures within the ovary and related structures. But for the most part, 90% of them are epithelial in nature. And so the reason why that's helpful for us to know is that in general, certain kinds of chemo are more effective potentially than others. And that's why we want to make sure that we know what the pathology is. And luckily, again, 90% are this. So it makes the guidelines a little bit easier to follow. The median age at diagnosis is 70 years old.
63.
That's right. So it's fairly close to breast cancer, which means we usually have it kind of really separated out where we'll have people who are in their 70s being diagnosed, and then potentially people who are in their 30s and 40s. I would say the average age I see for ovarian cancer patients is probably a little bit younger. So I probably tend to see patients who are more in their 50s. And the good news about that is that I can use, unfortunately, some of the more toxic therapies to give them a better result and have them be able to live longer with the disease than some of my much older patients. Because unfortunately, one of the common side effects, right, is nausea and vomiting because we're using a lot of the platinums. So I'm able to kind of give them, more intense medication and not worry so much about like the Beers criteria and things like that when I get into dealing with much older patients. Any questions on that so far? Okay, moving on. Your patient on Avastin is getting ready to have an interval debulking procedure. What is an interval debulking procedure? What does that mean?
He's getting part of the tumor removed.
What was that? Can you say that again? Sorry.
He's getting part of their tumor removed.
Yeah. Is it, so does it usually like happen just once and then we're done, or?
Multiple times.
Mm-hmm. Yeah. So an interval debulking means we had a suboptimal debulking, right? So that means that when they went in for surgery, we saw that maybe we couldn't remove everything, or we didn't have really completely clear margins. Or for example, maybe somebody wasn't healthy enough to have like a major total hysterectomy, all the structures removed. So instead, we might do kind of like smaller procedures over time to help, again, do that cytoreduction, right? Which is just reducing the number of cancer cells. Okay, so the surgical fellow would like to know when to hold Avastin. So before we move on to that question, what is Avastin? What's the generic name?
Bevacizumab.
That's right. And what's its mechanism of action?
It's VEGF anti.
Mm-hmm. Perfect. So, sorry, I got hungry. So when you block VEGF, what kind of side effects can you have?
Bleeding.
You can have bleeding, right?
Or wound healing.
Or wound healing.
Hypertension, proteinuria.
Exactly. So those kinds of things we worry about when we're getting ready to do a big surgery, especially essentially an abdominal surgery, right? You've got all kinds of arteries, veins. I mean, it's a highly vascularized area because you want to make sure that all of these organs are getting, substantial levels of blood. Otherwise, your bowel will die. And you may have other organs that don't get enough blood supply. So we know that anytime we use something that can cause poor wound healing, GI perforation, right, all kinds of stuff, we want to withhold that from a patient. So what would be the correct response for this? And this was just a straight memorization, unfortunately, but it's a package insert.
Yeah, backwards. 6 weeks and 28 days.
Yep, exactly. So the reason why we came up with this particular number is really just that this was the washout period that they kind of decided during the trials was probably safe. It's actually different for colon cancer, which is interesting. But for ovarian cancer, this is really kind of the rule of thumb because, again, those surgeries tend to be much more extensive than some of the other kinds of bowel surgeries. Any questions with this one? Or any questions about Avastin? Any questions about life in general? Just making sure you guys are awake. I'm not. Okay. Which of the following are risk factors for developing, or I almost said organic cancer, sorry, ovarian cancer? Select all that apply. So pregnancy under the age of 35.
No.
Nope. Incidentally, for women incidentally for breast cancer, not for women, sorry. When is it protective for a woman to be pregnant? Do you guys remember? Was it less than 35 or a different number?
Was it 30?
Yeah, it's less than 30. So it's hard because women generally have both sets of parts, right? So we have conflicting information about when it's beneficial to have, to prevent breast cancer, when it's beneficial to prevent ovarian. There's a lot of debate still about this, but generally speaking, that is protective. So pregnancy over 35, we know that's not true. BRCA gene mutation, is that a risk factor?
Yes.
Yep. And there are multiple types of BRCA mutations. It could be one, it could be two. And there are other ones that are being identified. And then orthotricycline, is that a risk factor?
No.
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 Nope. In fact, it may be protective. Hard to know. Okay. So your patient has just completed 6 cycles of cisplatin and paclitaxel every 3 weeks. She returns to clinic 2 weeks after.
A question. Sorry to interrupt. Under risk factors, what do you mean by no use of oral contraceptives from that option right there? So you're not supposed to be using birth control?
No, birth control can be protective. So, for example, if a woman doesn't use any birth control, that actually may be deleterious for ovarian cancer. So, for example, women who've been taking birth control for a long time may potentially have higher rates of breast cancer, but not necessarily ovarian. So that's one of the reasons why we've had a lot of conflicting evidence on that.
Dr. Leva?
Yeah, unless I got that backwards. Hang on a second.
Well, I was thinking because if you are taking birth control, that means you are not at risk. If you're not using, then you are at risk.
Yep, hang
so
on.
wouldn't that option be not right?
Yes, hang on a second. Hang on a second. Teachers get things wrong all the time. Hang on. Let me pull this up here. I wrote this very quickly yesterday. Hang on. Let me actually pull up the ovarian cancer PDF because it's opposite for breast and for ovarian.
On the slides, I think it said pregnancy greater than 35. What is it, 30 or 35?
It's 35, but hang on one second. I'm trying to get to that slide for you guys.
Slide 4.
Here we go. Yes, it's greater than, okay, sorry. This is what happens when your teacher is exhausted. So you are correct that risk factors, I just did a dyslexic. I was like, what are not risk factors? Sorry, I apologize. So yes, pregnancy greater than 35, that's bad because you are basically bathing the body in more hormones later on. And so we know that there is an increased risk of developing ovarian cancer. Sorry about that. No use of oral contraceptions. So if I had said not using oral orthotricycline, then that would have been a correct answer. But if you do use orthotricycline, that actually is protective against ovarian cancer. Now, one of the ways to remember this, and remember I told you guys a story, I think, about actually I may not have told your class. In many parts of Africa, especially sub-Saharan Africa, researchers were finding that there were very low rates of reproductive cancers, breast cancer, and especially ovarian cancer. And they were really perplexed and they were trying to figure out, well, this doesn't really make sense because there are still BRCA mutations that are prevalent, about 5 to 10% of the population. But what they figured out was kind of a sad reality, and that is in areas where there were more famines, because there was a reduced availability of nutrition, women didn't ovulate as often. So women were ovulating maybe every 3 or 6 months, sometimes not ovulating for 9 months because they didn't have enough nutritional availability to actually be able to, kind of have the normal cycle. So anything that disrupts the constant release of eggs, probably decreases the amount of damage to those epithelial cells. Because if you think about it, every time the ovaries essentially burst, it's like a micro injury. And one of the things we know about cancer is that cancer likes to form when cells are constantly having to repair themselves. So that's probably one of the reasons why, for women who are taking oral contraception, it's protective. But on the opposite end of the spectrum, in that same slide, I also talked to you about the fact that if you use postmenopausal hormone replacement therapy, it increases your risk. So basically, the bottom line is different periods of your life, the more exposure you have to hormones, depending on, again, your age and other factors, it can potentially increase your risk of developing ovarian cancer. Does that make more sense? I'm sorry about that.
No, you're fine.
I didn't even read my own damn question, so it's that kind of week. Okay.
Dr. Leva, just so I'm gonna update the grading.
Mm-hmm.
So it should be only pregnancy greater than 35 in BRCA1?
Yes. I miskeyed it, didn't I?
Yes.
Thank you. Yes. It happens. Yep. It happens all the time. Well, it doesn't actually. Luckily, we try and prevent that, but okay. Any more questions on that? And I apologize. It's Thursday, right? Yes. Okay. All right. So your patient has completed. Yep. And this also may, Dr. Fox, this one might have been keyed wrong as well. It was supposed to say 32 weeks, but it's okay. Well, I'll see how it was keyed. Your patient has just completed 6 cycles of cisplatin and paclitaxel every 3 weeks. She returns to clinic 2 weeks after therapy for a scan and a checkup. According to the RECIST criteria, I don't know if you guys remember that from kind of the first lecture, but yep, it's just how we kind of are able to measure progressive disease, recurrence, etc. Your patient now has progressive disease. You would consider her to have what? So based on 2 weeks after finishing cisplatin, knowing what you know about potential response to cisplatin, what would you consider her to have? Platinum-sensitive disease? Nope.
Resistant?
Yep, exactly. So Dr. Fox, if it's keyed for resistant disease, it's correct.
All right, I'll double check that one.
Okay, thank you. When I write 2 sets of quizzes, I sometimes get them jumbled because, again, many questions. Okay, but that is correct. So do you guys remember at what point would we consider someone to have sensitive disease? What's the time frame?
More than 6 months from last carboplatin dose.
Yep, so equal then or more than 6 months after. This is a really important thing to remember because if a patient has carboplatin-resistant disease, we're going to have to completely change up their therapy. So this involves potentially using combination agents or using, third-line agents. Sometimes we have to use salvage therapy for these patients. So that's a really important concept to remember because, this is essentially a treatment paradigm for these patients. Any questions on that?
And this one was keyed correctly as platinum resistant.
Yes. Okay. I was just thinking of the other quiz question I wrote, which I think was 32 weeks. So, yeah. All right. Cool. Yeah. I see nods. They're like, yep, no, Dr. Livy, you're with us. Okay. Yep. Still here.
So did you say 6 months it would be resistant, right?
If it were less than 6 months, it would be resistant. Absolutely. Yep.
Okay.
And so in this case, sometimes the patient will actually be in 3 cycles in, and maybe their CA 125 starts going up and up and up, and then we do another scan and we see they're getting worse. And then that would mean immediately we're like, this isn't working. We're going to have to completely switch agents for patients midstream. So sometimes even in mid-chemo, we have to stop and then do something else. And this is not uncommon for ovarian cancer. We don't tend to see it necessarily as much with some of the other cancers. We'll often scan a little bit later. But for ovarian, if it's not responsive to carbo, it will blow through it very quickly, and even before patients have symptoms. So, okay. The 67-year-old patient with stage 3 optimally debulked ovarian cancer with well-controlled diabetes and hypertension with an ECOG of 2 and a KPS of 60 is an ideal candidate for intraperitoneal chemotherapy. Is that true or false? It's false. So what makes it false for this particular patient? There are a few things.
Comorbidity, so she has diabetes.
Mm-hmm.
And then her age.
Yep. And what about the diabetes specifically? Did we say is an absolute contraindication?
If it can cause neuropathy or neurotoxicity.
Exactly. In addition to that, we know that cisplatin and essentially bathing the peritoneal cavity with cisplatin can be very nephrotoxic as well. One of the strange things about doing HIPEC, or the essentially hot chemo, sounds like hot yoga. It's probably a lot less fun than hot yoga, although hot yoga does not sound like fun to me either. But one of the problems with this is we assumed at first that if we just bathed organs with chemo that it wouldn't be absorbed systemically. We really thought, okay, it's just going to be confined to this area. It's kind of like applying topical chemo. And what we found with a lot of studies is that it's actually equivalently toxic, if not more toxic, than giving someone intravenous chemotherapy. Patients still have nausea and vomiting, right? And often extreme nausea and vomiting, to the point where sometimes we have to really sedate patients for a little bit, or keep them as comfortable as we can.
She's pretty good at playing piano.
And that's one of the reasons why only 42% of women were actually able to continue on the full cycles of intraperitoneal chemo. So it's a very toxic, awful regimen, but it also gives an additional 16 months potentially for these patients. One of the things that I didn't necessarily mention, but it's important to know about stage 3 ovarian cancer as opposed to a lot of other stage 3 cancers.
It could be the
stage 3 ovarian cancer might as well be called stage 4, because it almost always comes back. And even if someone maybe is lucky enough to have a couple of years in between before it recurs,
it's kind of
it is extremely common for it to recur. And often when it does, patients will have, distant metastases. They'll have a malignant pleural effusion, or they'll have multiple other lymph nodes involved, or their liver, lungs, etc. So, it's one of the reasons why it's such an insidious disease. It likes to come back. So if we are able to do this procedure for patients, we're able to give them substantial amounts of time. But as Karen pointed out, the patient population is like this big compared to probably the total number of ovarian cancer patients who are stage 3, for example. Would we use this modality in a patient who is stage 4? No. The reason for that is because it's just so damn toxic. And because, a patient who's stage 4 probably already has compromised organ system and may not have a great performance status. So at this point, it makes more sense to really kind of stick to that stage 3. I did talk a little bit about how in stage 2 patients, there aren't any randomized controlled trials, but there's a discussion about, because this is such a difficult disease to treat, should we maybe do this earlier? But at this point, the evidence really doesn't point to doing that yet because it's so toxic. Any questions about intraperitoneal chemotherapy?
I have a quick question.
Sure.
So in this patient, the diabetes is well controlled. still we cannot give it, like just patient with diabetes is completely no.
Yep, it's completely no, because the problem is we know that their kidney function and their risk of neuropathies are already higher than the average person. And so a lot of providers just don't want to take the risk. Plus, having diabetes additionally adds potential cardiac risk factors too. And especially in somebody who's older, we worry about, again, putting their body under so much stress because it's an incredibly painful procedure that can cause electrolyte imbalances, acute kidney injury, things like that. So it's just a much more vulnerable patient population. Now, if she were 62 and had very well-controlled asthma and maybe very mild hypertension, that might be a little bit different, especially if she was otherwise really healthy and had great organ function, and good serum creatinine, all of that. Then they might consider it. But she'd also have to have a much higher performance status. So if you look at her ECOG of 2, it means she's already, dealing with, either having had longstanding diabetes for a long time and has some problems associated with it, or maybe the cancer itself has decreased her quality of life. And a KPS or Karnofsky performance score of 60% out of 100% is also kind of like, it's not ideal. So those are some of the reasons why we wouldn't consider it. But that's a good question.
What would be the cut? I am sure you said them in your presentation, but I forgot what the cutoff for ECOG and KPS.
Usually ECOG between 0 and 1, and there's not necessarily a KPS cutoff per se. It may be more institutional or provider driven, but I would say in general, most of us wouldn't want to do it below like 70%. And even 80% probably would be the more reasonable number, because we want someone to be able to survive this, right? It's an awful procedure and it's very risky, and we need someone, essentially for it to be effective, you have to be able to go through like 6 cycles of this. So if we're only able to do 1 or 2 cycles because somebody, already has a compromised baseline, then that, probably isn't worth the physical and emotional cost, and also cost of the healthcare system, because these people often need to be admitted to the hospital after this procedure is done. So the procedure is done in the hospital, and then they may have lengths of stay and things like that, and infections and neutropenia and febrile neutropenia and all of that. So
one more question that's probably out of box.
Love it.
Stage 3, and when you do like debulking, how do you know is optimally debulked or not optimally? And then how long? Let's say if someone do surgery and whatever they can see that's cancerous, they're gonna take it out. So it doesn't make sense to me. I cannot practically imagine that after surgery you can tell it is optimally debulked or not optimally debulked. Or you wait till certain interval to make the conclusion that whether it is optimally done or not?
Okay, so the way it's done is this. When a woman is first diagnosed, right, and she has the transvaginal ultrasound, CT scan, et cetera, they decide, okay, let's go ahead and do surgery. We're not doing any kind of fertility sparing surgery, right? We're just going to go ahead and do a full oophorectomy, remove the fallopian tubes, remove the uterus, and sometimes part of the cervix as well, depending. When they do that surgery and they're removing the structures, a surgeon actually will take cell scrapings and basically continuously put them under the microscope to make sure that they're not able to see, like the malignant cells, and sometimes they'll stain them also to provide better visualization. One of the other interesting things that they do is they do washings, right? So they'll wash the body cavity after they've taken the structures out, and they'll take samples of that and just look to see if those washings are clean. Because most cancer cells, especially ovarian cancer, tend to be poorly or undifferentiated. And because they're epithelial cells, it's really easy to see the disorganization within the cells. So a surgeon literally will just go through and continuously look. And then based on visualization of okay, I don't see any lymph nodes that look weird. I don't, we've sampled all these different tissues. I've looked at the cells. I don't see anything else. My margins are very clean. And usually with margins, it depends on the kind of surgery you're doing. But we like to see so much tissue that is free of cancer before we say a margin is clear. And some of it depends a little bit on the surgeon, unfortunately, because not all of that is standardized. And it also depends on the organ system. So once a surgeon is reasonably certain that they've gotten pretty much all evidence of obvious cancer and the cells, they can say, you know what, this was an optimally debulked cancer. If they go in and they see, oh man, I see a lymph node, that's stage 4, or I see something attached to the bowel and it's really deep into the bowel and we have to remove a section of bowel, but I still think that there may be some micrometastasis, then that might be a suboptimal debulking procedure. So unfortunately, it's really prone to human error. There's just not a good way to know for certain unless we use some kind of detection pen or whatever to be able to see how far in the micrometastasis go. And that's probably why ovarian cancer keeps coming back. It probably never left. We just have this sense of false security that, okay, we got all the cells, but based on the fact that it consistently recurs even after optimal debulking procedures, I think probably it's still there. So I hope that cleared up.
Thank you.
Yeah, no problem. That was a great question. Okay. So AD
inspired by Grey's Anatomy. Yesterday I see the surgery. They were taking out bone cancer. And they decided to do entire hip replacement because the part of hip was cancerous.
Mm-hmm.
So that's why my question comes how do you know it's optimally debulked or not?
Yeah. And it's really, it's the same principle regardless of the procedure. So, or regardless of the organ system. Even for skin cancer, right? We do something called a Mohs procedure. And that basically involves the dermatologist just cutting off layer upon layer upon layer upon layer of skin until there's no more cancer left. And that can really leave, major scars for patients. But it's kind of a rudimentary and fast way of being able to see if someone still has cancer. So same principle. Cool.
Thanks.
And I'll have to watch that Grey's Anatomy. I love Grey's Anatomy. Even though I yell at the TV half the time because I'm like, we wouldn't do that. But that's okay. All right. So AD is receiving her 6th dose of chemotherapy. Approximately 15 minutes into the infusion, she begins to have an allergic reaction. Which drug is likely responsible? What do you guys think?
Platinum.
Platinum, right. What is platinum? Don't all shout at once.
Cisplatin.
Exactly. What's Gemzar?
Gemcitabine.
Mm-hmm.
Or
Gemcitabine. What's a pretty substantial toxicity associated with gemcitabine that you guys are going to draw about later?
Bone marrow suppression.
Yeah, bone marrow suppression. Bone marrow suppression is probably one of the most important things. If I can get you to remember Gemzar, gemcitabine, bone marrow suppression, the rash can actually be pretty substantial too. But the other thing associated with Gemzar has to do with infusion times. So do you guys remember, is a longer infusion better or a shorter infusion better?
Shorter.
Yeah, shorter. It's so strange. None of us can understand why, if we give it more than over 60 minutes, that there's an increased risk of neutropenia. It doesn't make any sense, but that's the way the cookie crumbles. All right, and what's a Votrient?
Pazopanib.
Pazopanib. And what's its mechanism of action? Do you guys remember?
VEGF blocks VEGF.
Yep. So it's a multi-kinase tyrosine kinase inhibitor, right? So it has a couple different modalities. Perfect. All right. Now, for Taxol, when do we expect allergic reactions from Taxol potentially?
Within the first 3 doses?
Exactly. And we generally, we always prophylax with a variety of different drugs like H1, H2, and steroids. So that pretty much helps prevent most of the severe reactions. But on occasion, someone will have like a breakthrough reaction when they're receiving usually between doses 1, 2, and 3. Perfect. Okay. EW is a 42-year-old trans man with stage 4 ovarian cancer and is going to begin IV topotecan days 1 through 5 every 21 days until progressive disease or unacceptable toxicity. Which of the following common ADR should you counsel him on?
Bone marrow and diarrhea.
Diarrhea and bone marrow suppression.
Yep. So topotecan, just like irinotecan, I ran to the can. Yep. And it is a very crude mnemonic or silly kind of thing to remember, but it really does help. So whenever you think of topotecan and irinotecan, I ran to the can. It causes such severe diarrhea that I've had patients admitted, and we've lost patients because of it. So it is, I cannot stress enough how serious the diarrhea can be. And it doesn't matter if you're taking it orally or getting an IV, it's still equally dangerous. It's pretty low emetogenic risk, even though, sometimes people will report some mild nausea and vomiting. Interstitial lung disease, I did talk about that, but there's not necessarily an increased risk of cardiac events, and that's pretty rare. Arthralgias and hypersensitivity reactions, that's really more with like taxanes, and also carbo and cis. And then vesicant potential. Was it a vesicant? Do you guys remember?
Doxorubicin?
Doxorubicin is a vesicant, absolutely. But is topotecan a vesicant?
No.
Okay. But it does have another name that we use for it, right? Is it a completely no big deal, I can just give it and it's not going to hurt anybody's veins?
It's an irritant.
It is an irritant, exactly. Now, irritants, the difference between a vesicant and an irritant is that irritants will burn and be really uncomfortable for patients, and it can be very scary for them, because if you're running a line peripherally, like just in a small vein in a hand or an arm, and you feel a burning sensation or aching, that's very uncomfortable, and it can be scary for patients, and frankly, it can be scary for nurses too if they're new and they think someone's having an extravasation. But the difference between an irritant and a vesicant is that a vesicant will burn and do all that stuff, but if it extravasates, it'll actually damage necrosed tissue. So people can lose limbs. People have had to have major surgery around their port area when vesicants leak out into places that they shouldn't be. But that's not really the same thing for irritants. They can do a little tiny bit of damage, but mostly it's just major irritation. So that's the difference between the two of them. And as we go on, we'll talk more about drugs that are vesicants and irritants. So carboplatin and cisplatin, technically at higher concentrations, can also be irritants. And paclitaxel, some of the taxanes, there's a little bit of controversy over whether they're irritants or vesicants, and I've seen them do pretty bad damage. So I'm more inclined to call them vesicants, just because I've had to get dermatology or plastic surgery to come in and do consults when that leaks out too. So when you're going through these drugs, try and think about focusing on the kinds of side effects that, as a pharmacist, you need to be able to provide drug information. So if like a nurse calls you up and says, oh man, we had a carboplatin inpatient extravasate, what do I do? So you ask the question, well, let me check the concentration of the drug that we made. And then you can tell them, nope, you're okay. Just stop the infusion, blah, 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 blah. So we'll talk a little bit more about this stuff as we go on, but this is definitely important stuff to remember. All right. Any questions? Okay. So a 52-year-old patient with stage 4 ovarian cancer is going to be receiving bevacizumab with liposomal doxorubicin every 3 weeks until she has progressive disease or unacceptable toxicity. You're going to see that term used, unfortunately, all the time. When it comes to her bevacizumab, what should we monitor at baseline and regularly during her treatment? And we did kind of answer this before, but let's do it again. So would we do a urinalysis?
Yes.
Yes.
Yeah. What are we trying to catch if it's happening?
Proteinuria.
Right, which is usually caused by, what's the syndrome that we refer to it as?
Nephrotic syndrome.
Exactly. Because remember, your kidneys get 25% of your blood. You cut off that or you damage access to blood flow, and all of a sudden you can start having all kinds of damage within the kidneys, and usually in the form of proteinuria. What about blood pressure?
Yes.
Yep. Yeah, because it's also a treatment parameter, right? So if I have a patient whose blood pressure is 165 over 90, nope. Yeah, and I won't give you, like, if I give you a blood pressure, it's going to be obvious. I'm not going to be like 161 over like 89, or, you know, like I'm not doing any of that. Because most places have like a cutoff of either a combined systolic diastolic of 160 over 90, or they have like systolic diastolic cutoffs. But this is kind of the general rule of thumb. What about LFTs? Do I worry about LFTs?
No.
Nah, not really. You know, if somebody's on liposomal doxorubicin, then yeah, probably we would. But I was just talking specifically about the BEV. What about CBC with DIF?
Yes. Yes.
Yeah, why?
The risks for DVT, PE,
So
bleeding that might be occurring.
yeah, so for DVT PE, what within the CBC with DIF, what do you think specifically we're looking for? Because we definitely worry about thrombotic events for sure.
Like the risk of clotting or like not being able to clot? Is that what you're asking?
Yeah, so what I'm asking for, so unless we do like a D-dimer or
Basically wound healing, if we're not going to have enough.
yeah, so delayed wound healing is something we visually see more than we pick up from a CBC with DIF. But the big thing that a CBC with DIF can show is if someone's actively bleeding, right? Like if they have a slow leak somewhere or if they have a significant bleed. And if you have a significant bleed internally, but you don't have any symptoms, which is not uncommon, especially a GI bleed, and maybe they just haven't noticed it in their stool or whatever, or maybe they're taking iron supplements and their stool is already dark and they're like, oh yeah, I was told it was supposed to be dark. So CBC with DIF, like just hemoglobin, hematocrit, and platelets, those are a really good first indicator that something's going on. And if someone has really high platelets, back to your point, Ryan, right, then we can think, they may have some hyperviscosity syndrome. They're at increased risk for clotting. We may want to consider using aspirin or something like that. So CBC with DIF is a nice, cheap, and easy way to get a quick picture and then decide from there, you know, if you have symptoms of a DVT, yeah, we can do a D-dimer. We can do an ultrasound, especially if someone has like, you know, actual symptoms, or we can do a VQ perfusion scan if, you know, we're concerned about clots in the chest. But this is one of the ways that we can kind of get a baseline and then monitor patients over time to see if anything is changing. Does that make sense? Rock on. All right, Gemzar is a cell cycle phase specific anti-pyrimidine agent that is moderately emetogenic and is extremely myelosuppressive. True or false?
False.
False. What part is false?
It's low instead of moderately.
Exactly. So one of the things that we like about Gemzar, despite the fact that it has, like, again, severe myelosuppression and fatigue associated with it, is that it is a low emetogen. So I can often get away with just giving somebody a, small dose of Dex or a small dose of Zofran. I like to give Dex when I can for these patients because it helps prevent the rash. Also, it helps give them a little bit of a boost of energy because Gemzar is known for just causing extreme fatigue. Some of the fatigue is not necessarily related to like it being very bone marrow suppressive. Patients just complain of significant fatigue while they're on it. So giving them a little bit of a boost, especially that they get the drug, can be helpful. And it deals with the nausea, right? Because it's a low metagen, so you can go ahead and give them a dose of that. All right, awesome. I apologize for the confusion with that one question. And I appreciate you guys being patient and good-natured as always. Okay, I'm going to give everybody a quick, actually, I'm going to give you guys a quick break, but before I do that, we have a couple of options of how we can do this. So I wanted to go over the breast cancer application, just kind of finish that up with you guys. And I also gave you a chemo person for today's activity because I know that just having the ability to do that, and you can continue to do that with each of the subsequent applications because it's helpful to remember the drugs and what they cause and all of that. So we can either have you work on that as a group for a short period of time, and then we can have everybody come back and we can just go through the entire application. Do you think that would be okay with you guys? Or we can just kind of muscle through some of it now, but my preference is to let you guys kind of translate some of the stuff you learned from the previous exercise and put some of that on your chemo person too. So, okay. That sounds good. So we'll do that. Why don't we come back at